Please proceed. The audience is all yours now.
Good afternoon, everyone. So sorry for the technical issues. Today I'll be talking about cancer-related fatigue, and what is cancer-related fatigue basically? The National Comprehensive Cancer Network, that is the NCCN, it defines a CRF, that is cancer-related fatigue, as distressing, persistent, subjective sense of tiredness or exhaustion related to cancer or cancer treatment that is not proportional to recent activity and interferes with usual functioning. Okay, what does this statement mean? Basically, you and me, every one of us gets tired, right? Morning when we start our day, we are like full of energy and we are ready to take on all the challenges that come throughout the day, right? But as the day progresses, by evening, our body is short of all the energy resources and it feels tired, right? Now, suppose on a weekend, if you suddenly plan to do a deep cleaning of your house, or say go on a hike with your friends, or go cycling, do some unusual activities which you don't practice on a day-to-day basis, then on that particular day you will feel very tired, exhausted, like you are not in a mood to do any of the other work, right? So that is what is fatigue, where all your energy resources are used up and you can't do anything further, right? But here we have a reason for that fatigue. Okay, because we did XYZ activities, we are tired. And the main thing is, after this tiring day, when we rest, the next morning we are again fresh. Maybe after a heavy activity, we might have some muscle soreness or something, but apart from that, like, it's not stopping you from doing anything further, right? So because of that, like, we are fresh and we can do all the activities on the next day. But in cancer patients, what happens is, this fatigue is not proportional to their activity level. Maybe the patient has just woken up from sleep and is already feeling tired, is already fatigued, is not willing to do any other work. Okay, so in cancer patients, not necessarily that the patient has done a lot of activity, has gone to the hospital, has had his treatment, multiple consultations, and then he's feeling tired. No, even after normal day-to-day activities also, he might feel tired. Okay, and even if the patient is resting, say the patient is feeling tired, so he or she sleeps for a while and gets up, but still there might not be any change in the fatigue levels. Okay, so that is the main difference between a normal fatigue and cancer related fatigue. Okay, so fatigue, as I said, it's a normal physiological process, a response to exertion. Okay, but it will become pathological when it occurs during the routine activities. So getting up in the morning, getting ready, having breakfast, this should not be tiring. But if it is becoming tiring, that means it is pathological, like it is something to worry about. Okay, if it is persisting for a long period of time, okay, then you need to worry about it, and it's not responding to rest, like you have rested enough, you have had a good sleep, but still that fatigue is still persistent, then you need to worry about it. So let's let's have an overview of fatigue. So fatigue basically is the most common symptoms in patients who are undergoing chemotherapy, radiation therapy, or bone marrow transplant. Okay, so research says that almost 80 to 90% of patients do suffer from fatigue. Okay, but the problem is, usually it is underreported. Okay, why does that happen? Because patients might think that if they complain about fatigue, then their treatment might be changed. If suppose they are on chemotherapy and if they say complain about fatigue, the doctors might change my drugs or might not give me the required dosage, is what the patients might end up thinking. Okay, or sometimes the patients might think that I'm complaining too much. okay, because they have a lot of symptoms. There are a lot of side effects of these drugs or this treatment. So they might, every time when they are visiting the clinician, they might end up saying some of the other symptoms, and then they themselves might think that no, this is like, a lot of complaining. Okay, so that's why, and they avoid reporting it. Okay, and also sometimes the patients think that no, maybe this is the normal this thing, like, this is the side effect of the treatment, and I have to bear with it, I have to live with it. Okay, so because of all this thinking from the patient's point of view, fatigue goes unreported, underreported rather. Sometimes the clinicians might not be able to diagnose it properly. Okay, the clinicians might think that it's not a major problem because the patient is not complaining of anything. Maybe it's not a major problem to the patient, so it's fine. Okay, sometimes the clinicians themselves might not be aware that there are treatment options available for fatigue. Okay, so that is why fatigue can go underdiagnosed. Okay, and because of these two reasons, because it is not reported and because it is not diagnosed, it can be undertreated. Okay, but persistent fatigue can affect the quality of life. Okay, because since the patient is fatigued and unable to do the day-to-day activities, or the family life gets affected, the social life gets affected, the mental well-being gets affected, and all this impacts the quality of life. Okay, now what is the pathophysiology of fatigue? So basically, whether CRF, that is cancer related fatigue, a physiologically distinct mechanism, or there are multiple factors which lead to a common pathway and they cause fatigue, this thing is not yet known. Okay, the exact pathophysiology is not known, though researchers have put forward various mechanisms which might cause fatigue, okay, along with other factors which we will see later on. But there is no one particular thing which is sure that this thing will cause fatigue. No such thing has been determined yet. So now the proposed mechanisms are presence of pro-inflammatory cytokines, or the hypothalamic pituitary adrenal axis dysregulation, or the circadian rhythm desynchronization, skeletal muscle wasting, genetic dysregulation. Okay, so all these mechanisms are pretty complex and intermingled with each other. So we cannot go into the details of it, but we'll just see what it does, like how it affects the body. So for example, pro-inflammatory cytokines. Now, when the cytokines are present in the body, they will have an effect on the neuroendocrine system. Okay, so such as the HPA axis, and they will have effects on release of corticotropin releasing hormone and the ACTH and everything. Okay, so if this axis gets there is some dysregulation in that, then that will again lead to more fatigue. Also, when cancer as a disease is present in the body or the treatment is going on, some amount of inflammation is present throughout the disease process. Okay, so some amount of inflammatory markers such as the C-reactive protein or the interleukins, they will be present in the body. Okay, and because of this constant presence of these inflammatory factors or markers, also the fatigue can set in. Now the HPA axis dysregulation. Now what is a normal HPA axis? We will see. So whenever there is stress in the body, the hypothalamus will release corticotropin releasing hormone. Okay, now that will act on the pituitary gland and it will release the ACTH, that is the adrenocorticotropic hormone. That will act on the adrenal glands and it will release cortisol. Okay, now this cortisol is helping the body, like preparing the body for flight and fight response, right? Now, when there is okay, so when there is fight and flight response, and then there is enough level of cortisol, then automatically it signals the hypothalamus to reduce the release of CRF and ACTH. Okay, so then the body starts relaxing. In normal levels, normal concentrations, cortisol will help the body to repair and regenerate. But if the levels go up and down, then it will again disrupt the system. Okay, it might just lead to constant stress. If the level of cortisol is less, the level of stress would be there present in the body. So again, that will cause fatigue. Okay, if there is circadian rhythm desynchronization, then the patient might have problems like falling asleep. The patient might have like if the patient has fallen asleep, he might have problems staying asleep. He might just wake up after a short interval. Okay, then because of the improper sleep in the night, patient might experience excessive daytime sleepiness. Okay, then because of irregular sleep, again there might be fatigue, lethargy. Okay, difficulty concentrating on important tasks. Okay, or difficulty in having proper judgments. Okay, or controlling the moods and emotions. Right. Now, coming to skeletal muscle impairment or wasting. Now, what happens? There are multiple factors which we will see in the next slide. So, like for example, if there is anemia, which is very common in cancer patients because of some treatments. So, when there is anemia, automatically the oxygen carrying capacity of the blood will reduce, and because of that, the muscles won't get enough oxygen, and thus muscle fatigability will be evident, right? Many a times, if there are any lung surgeries which are happening or radiation to the chest wall might lead to some lung fibrosis. So the lung functioning will be affected, because of which there might be VQ, that is the ventilation perfusion mismatch might be there. And because of all these reasons, again, the muscles might be easily fatigued. Okay. Similarly, if the patients, like when anyone, like even you or me, feel sick, we would like to rest for maximum time of the day, right? So same way, because these patients are undergoing such a aggressive treatment, they would like to rest for most of the time, right? So because of prolonged bed rest or presence of corticosteroids or prostaglandins, there might be atrophy, muscle atrophy might be seen. Okay. Also, there is disruption of excitation contraction coupling because of tumor necrosis factor or the radiation which is present in the body. So because of that, again, the muscle functioning will be affected. Now, what are the other factors? Now, we have spoken about the disease, the treatment, but other factors like pain, anemia, or sleep disturbances, nutritional deficiencies, emotional distress. Okay, all these factors combined together, and they also might cause fatigue. Okay. Now, why don't we have enough data, epidemiologic data for fatigue? Now, there are various reasons for that. For example, fatigue is very subjective in nature, right? Well, unlike same like pain. Now, we can't say that after a particular surgery, on day one, patient will have a VS score of 7, or it reduces to 5 by day 2, because it's again a subjective measure, right? Same way, even fatigue is a subjective measure. So we cannot quantify it saying, okay, during the starting of the treatment, patients will usually have this much fatigue. Towards like patients undergoing chemotherapy will have this much amount of fatigue. Okay, that becomes difficult. So we don't have a proper data about that. Then fatigue can occur and recur at various stages of the disease or the treatment. Okay, suppose when the disease there is a recurrence, the fatigue levels might increase. When there is metastasis, the fatigue levels might increase. Okay, so say there are various ups and downs basically in the fatigue or this thing. Then there are a lot of measurement tools which are available. Okay, now because there are so many tools available, different institutes could use different tools. So then sticking to one particular tool is little difficult, or data about one particular tool or its usage is little difficult. Okay, then as we discussed earlier, changing pressures of under or over reporting. Now we saw the reasons for under reporting, but at the same time, over reporting can happen if other symptoms are taken care of, right? If the patient is having pain, nausea, vomiting, or other things, so if they are controlled, then the patient might shift the focus towards fatigue, and then might start reporting about fatigue. Till then, the other symptoms, if they are overpowering fatigue, the patients might not realize that he or she is having that much fatigue, right? And again, same thing, like if, because fatigue is associated with many other factors like depression, anemia, pain, vomiting, nausea, everything. So fatigue would be basically considered as something which can be, which the patients might not bother. They might think that because of the treatment, these things are happening, and feeling tired. Okay. Now, how do we evaluate fatigue? So basically, there are 4 steps. First is screening, then primary evaluation, intervention, and re-evaluation. So in screening, what do we do? First thing, and not necessarily this has to be done by a physiotherapist. Even the clinicians can do these things. Okay, when the patients are visiting a clinicians, even they can screen for presence or absence of fatigue. So first we have to check if fatigue is present or no. Okay, then screening has to be done at various stages, like at diagnosis, then during the treatment, and also during the long-term follow-up. Okay. Now, if the patient says that he or she feels tired, so you have to quantify. And the simplest tool for quantifying is the NRS. Same like pain scoring, we can take scores for fatigue. So when the patient says he has fatigue of 0 to 3, that can be considered as mild fatigue. 4 to 7 can be moderate, and above 7 can be severe. Okay. Now, not always will the patients think that they or realize that they are suffering from fatigue, okay, or fatigue is affecting them in a negative way. Okay, so we can always ask the relatives also, the family members also, because they might definitely notice some change in the activity levels of the patient or the behavior of the patient. So that also will give us an idea whether the patient is fatigued or not. Okay. Then, as I mentioned, there are various scales which can be used. The most simplest one is the BFI, that is the brief fatigue inventory. So it will basically ask questions like how much was the fatigue in the last 24 hours? Then what is the usual level of fatigue that you experience, or what is the worst level of fatigue that you have experienced? And how is fatigue affecting your day-to-day activities like general mobility, walking, emotions, your relations with other people, etc. Okay. Same way, there is a multidimensional fatigue inventory, that is the MFI. Now, multidimensional name itself suggests that it takes various components into consideration, like the physical well-being, the mental well-being, the social well-being, fatigue, etc. Okay, so and it is a 5-point scale from 0 to 4. The patients are supposed to mark how much fatigue they experience, and accordingly, then the scoring has to be done. Okay, same way there is FACIT also, but FACIT, that is the functional assessment for chronic illness therapy, is a scale which is generally used for anemia, but it has a fatigue subscale that can be used. Same way, EORTC is a quality of life scale, but it has a fatigue subscale. So these are few of the scales which are used, but there are a lot more. Then once you have found out that the patient has moderate to severe levels of fatigue. So once the score is above 4, you have to do a primary evaluation. If the score is below 4, you can just educate the patient about what fatigue is and how it can change over the period of time or with the course of treatment. Okay, and how like you can just make the patient aware about the fatigue and its changing levels, and what when should the patient report to the physician. All those things can be explained to the patient. When it is more than 4, that is moderate level starts, so then you have to do a proper assessment, and mostly this will be done by the physician. So basically the current status of the disease, the length and type of treatment, then patient's response to the treatment, all those things have to be considered. If there was any hospitalization for recurrence of the disease, or is there any increase in the disease burden, because that might also lead to fatigue. Okay, then a lot of people in our country especially, they would like to opt for other forms of medicine like homeopathy or ayurveda or any other this thing. So it's better to always check if the medications have any interaction with this alternative medicines. Okay, because sometimes some medications or some components might interact and they might contribute to fatigue. So then in that case, something needs to be changed. And also associated symptoms like sleep disturbance, pain, vomiting, nausea, nutritional deficiencies, all these things also need to be rectified. Now, intervention. Again, in intervention, the reversible factors that we have been talking about, that needs to be taken care of. Like anemia has to be corrected either by blood transfusion or by giving medications. Electrolyte imbalance has to be managed. Pain has to be controlled. Okay. Apart from that, there are 4 main components which the NCCN describes, and that is education and counseling of the patient, general strategies, non-pharmacological management, and pharmacological management. Okay. So now in education, as I mentioned, the patient has to be explained about fatigue and its natural course. Okay. It would be better if at the diagnosis itself, the patient is informed about these things, because later on, more or less, the patient is going to experience fatigue at some point or the other. So it's always better that patient has some idea about it in the beginning itself, so that it's easier for him to identify. Okay. Explaining everything about fatigue is important, and making the patient understand that this is going to be a consequence of the treatment. Okay, not necessarily that it's going to be an indication that no, the treatment is not working for you, or the disease is spreading and that's why you're feeling weak and fatigue. That is not the case. So this has to be made clear with the patient. Then also along with the patients, informing the family members is also important, especially for the patients who are on treatment. Again, because for them, the likelihood of experiencing fatigue is higher. Okay, so even the family members need to be aware that these are the kind of things that the patient might experience. Okay. How to recognize it earlier and how to self-monitor the levels of fatigue. All those things have to be explained to the patient. Now, what are the general strategies? In general strategies, something like energy conservation techniques can be followed. Okay. In that, like for example, delegation of activities. Now, in an Indian household, if you consider, a female is always putting the family, kids, and everyone else before her. Okay. So even if she's sick or she's not feeling well, but she will see to it that everyone else is comfortable, and then she will think about her own self. Okay. So in this case, it's better, even like understanding by the patient and the family members is important, that the energy has to be conserved. Okay, so for that, delegation of activities is important. So maybe if there are 4-5 members, so each member can take up one task. One person can take up the task of cleaning the house, one can take up the task of cooking, and so on and so forth, right? So delegation of activities is very important. Whatever things can be done by others should be done by others. Okay, whatever is very important and has to be done by the patient himself or herself can be done by the patient, but other things can be done by others. Then use of assistive devices. So for example, to pick up something from the floor, the sticks can be used, which will help. Or for example, if there is any old lady with a pre-existing osteoarthritic knee with a severe knee deformity. Now, if she has to get up from the bed and go to the washroom, that also will be like a big task. With that deformed knee, walking also will be a big task. So in such case, you can give her a walker with wheels. So it will ease her task, right? So such kind of modifications can be done. And for example, if the patient is like the washroom is away from the patient's bed, the patient finds it difficult to go all the way to the washroom and come back, a bedside commode can be arranged, right? So all such small modifications can be done, which will help in conserving the energy of the patient. Okay. Now, certain distractions like games, soft music, or maybe now in the times of virtual this thing meetings and all, social interaction, virtual meeting with friends of the patients, that can be arranged. So all these distractions have shown to help, but how, the reasons are not clearly known, but all these things will definitely help the patient. And maintaining a fatigue diary is something that we advise the patients. So what is a fatigue diary? It is something like this. Basically, for every hour, every hourly, what major activity the patient has done, that has to be described. Before that, date has to be mentioned, and how well did the patient sleep last night, or what was the quality of sleep, that has to be mentioned earlier. Okay. Then whatever time the patient gets up, from that time onwards till the patient sleeps, every hour has to be charted. So what activity has the patient done? Okay. What was the level of fatigue? Okay. How important that activity was for the patient, and what is the level of satisfaction by doing that work? How satisfied is the patient? So that has to be mentioned. Here, fatigue type and comment. So what type of fatigue was the patient experiencing? Was it a social fatigue? Was it a physical fatigue, or a mental fatigue, emotional fatigue? Okay, so these different types of fatigue are there. So out of that, what exactly was the patient experiencing? And if the patient has to add any specific comments to that, that can be added. Okay. Then basically this fatigue, importance of the activity, and the satisfaction, that can be measured on the scale of 1 to 10, where 1 is like not at all and 10 is extremely high. Okay. And at the same time, there is a scale for interference. So how much did fatigue interfere with the activities? So that can be from 0 to 10. Okay. So this is a basic diary which we ask the patients to maintain, so that they also get a general idea of when, in which part of the day does the patient have good amount of energy, which part of the day the energy levels are little lesser. So accordingly, the task can be divided. So the important activities which are very important and the patient has to do it can be done when in the time frame when the energy levels are high. Okay, the lesser important activities can be done when the energy levels are little lower, and the least important activities can be definitely delegated to somebody else. Okay. Then coming to the non-pharmacological management, in that first is strengthening and endurance programs. Okay, so first and foremost, we need to assess for the deconditioning, the level of deconditioning. Okay, if there is high level of deconditioning present, then we have to start with very low levels of activities. Okay, we cannot directly jump to some strength training or resistance training for that matter. We just have to increase the activity levels of the patient. Maybe, for example, if the patient is getting up 4 times to go to the washroom, we need to add one more round apart from the washroom thing, where we ask the patient to just get up from the bed, walk in the room and sit down. Maybe that is on first or second day, we ask them to do that. Then the third day, maybe we can, instead of 1 round, we can ask them to go for 2 rounds, like that. So gradually you have to increase the activity levels depending upon what is the baseline. Then again, patient education is very important, and in all these cases, the extremely difficult thing is convincing the patients for exercise. Okay, because the patient, usually the tendency is that we are already very weak now, why do you want us to exercise? Okay, so to explain the importance of exercise, to convince the patients that these activities are going to make you feel better instead of making you feel tired, that is very important. Okay, because generally everyone thinks that no, if I'm diagnosed with cancer, then the only treatment options are chemotherapy, radiotherapy, surgery, that's it. So importance of exercise or nutritional corrections or sleep or psychological counseling, all these things are like secondary for the patient. Okay, but we need to convince them, or we need to explain to them how important these things are along with the mainstream treatments. Then second thing in non-pharmacological intervention is the psychosocial interventions. Okay, so now psychosocial interventions would include stress management, because as I mentioned, patients are, the diagnosis of cancer itself is very distressing for the patient and the family members itself. Okay, plus if the patient is a earning member of the family, then it puts a lot of financial burden on the patient, on the family. So all these things lead to a lot of stress. Okay, stress management is important, relaxation is important. Okay, and support groups. For example, if the patient has younger kids who need to be taken care of, but the patient has to come to the hospital for treatment and there is nobody to take care of the kids, again that would add to the stress of the patient. So connecting the patient to some support group or help group where the kids can be taken care of, so that will really reduce the stress of the patients. Okay, or for example, many people lose their job once they have been diagnosed with cancer and they're undergoing treatment, they're absent from work, they might lose their jobs. So then again, introducing them to some groups where they can maybe learn some skilled task and they can earn a livelihood. Okay, that would be better. So all these factors are also important along with treatment, other treatments. Then alternative therapies like acupuncture, yoga, massage, all these things also will have shown to help in reducing fatigue. Then nutritional management. Now, nutritional assessment is also very important. If there is sudden weight gain or weight loss, that needs to be identified. What is the reason for that? Then there can be dehydration. So the importance of hydration has to be explained to the patients. Then fluid electrolyte imbalance has to be corrected. Okay, caloric intake has to be changed according to weight gain or weight loss. Then there can be imbalance in calcium, iron, potassium, magnesium, all these things which can be corrected and which has to be corrected. So for that, nutritional management is also very important. Sleep optimization. Now, sleep disturbance is one of the very common symptoms or very common problem that the patients face. Okay, and what happens is most of the time they are sleeping or resting, but then the quality is not very good. Okay, so that's why they have a very disturbed sleep, and because of that also they might feel very tired and lethargic. Okay, now there can be various reasons for this poor sleep hygiene. Okay, one can be individual habits, like for example, if someone is used to like if the screen time, especially at the night time, is more, that might affect the sleep quality. If patient is living in a small house and there are a lot of family members, so there can be a lot of chaos around, because of which the sleep quality might not be good. Then if the patient is not able to relax before the bedtime, if the patient is constantly anxious or thinking about what the future has in store for him or her. So that might again lead to poor sleep hygiene. Okay, or if the patient is sleeping in the afternoon, so then the nighttime sleep will be compromised, right? Or if before the bedtime the patient has had caffeine intake or alcohol intake or high sugar intake, then again that will affect the bedtime, the sleep hygiene, right? So how can the patients improve the sleep quality? So for that, maybe we can encourage the patients to start writing down the maybe positive things that they have done in the day, or whatever they want to, how the day went, or what were the thoughts about that day, or so all these things can be written down. They can start practicing yoga or meditation. Okay, then they can listen to quiet music, which is very soothing and relaxing, and avoiding late night gaming or TV or mobile use. That will help in improving the sleep quality. Now, in pharmacological management, any underlying problem which can be corrected by the use of medication has to be corrected by the use of medication, like anemia, pain, inflammation. All these things can be taken care of by various medicines, right? Now the re-evaluation phase. Now, as we saw that fatigue can rise and fall on multiple occasions. So even when the patient is coming on a long-term follow-up, the fatigue re-evaluation has to be done. Okay, and when we reassess fatigue, we can modify the treatment as well. Okay, if we feel that okay, now there is significant improvement in the fatigue levels, so maybe we can progress with the exercises, we can add up to the resistance, or we can add up to the intensity of the exercise that way. Okay, then coming to physiotherapy interventions, what all we can do. So now exercise has really shown to have a very high evidence in improving fatigue. There are lots and lots of studies which have been done regarding exercise, effect of exercise on fatigue. So now exercises are not only helping in improving fatigue, but aerobic exercises have also shown to improve the sleep quality, has shown to reduce the stress, anxiety, depression, all these things also. Okay, so along with fatigue, all the other factors are also improving with exercises. So and there are various studies, some have concentrated on aerobic exercise, some have concentrated on resistance exercise, some on combination. But one thing, in a lot of studies, all these exercise regimens have been given for a long period of time, like at least 6 months, 1 year, like that. But before prescribing any exercises, what you have to take care is the presence of bone metastasis has to be ruled out. Okay, because if there is any metastasis in the bone, so any impact, high impact activity or high resistance activity might lead to the fracture of that particular bone. Okay, so that has to be ruled out, that has to be taken care of first. Okay, then thrombocytopenia, that is if the platelet count is very low, then again there are chances of bleeding. So then in that case, you have to be careful. First, let the counts improve, and then you can add with the intensity of the exercise. Okay, same way anemia. If the patient is anemic, if you are adding up to the exercises, then again the patient might feel more tired. Okay, if there is any active infection or the patient is having fever, let it subside first, then you can start with your exercises. And if the patients are at risk of fall, you have to be extremely cautious around the patient, because if the patient falls, maybe he might have some other complications because of that, and you want to avoid that. Now, ACSM, that is the American College of Sports Medicine, gives guidelines for cancer patients and survivors. Now, they haven't specified for fatigue as such, but 80 to 90% of cancer patients are having fatigue. So this can be used in the patients depending upon their activity levels or the baseline. So now aerobic exercises, around 150 minutes of moderate intensity activities can be done, and 75 minutes of vigorous intensity exercises. Same way resistance exercises 2 to 3 times in a week can be performed, but flexibility exercises have to be done, that is the stretching exercises have to be done on all the days. Okay. Then in cancer patients, usually it will be exercise, like in general, when we prescribe exercises for any patients, it's custom made, it's tailor made for that particular patient. In cancer patients, all the more you have to change, and in cancer patients it can so happen that you have to change according to the, again, the energy levels, or according to the treatment of the patients. Because for example, if the patient is on chemotherapy, so on the days when he or she is administered chemo, the 2-3 days after that, the energy levels will be really low. So again, you can't keep on continuing with the same amount of resistance exercise. You'll have to cut down on it, right? So that way, depending upon what treatment and what is the status of the patient, the exercises will modify. Okay, so for exercise prescription, you have to take into consideration the health status of the patient or the disease trajectory. If the disease is progressing or if there is recurrence or whatever it is, you have to take that into consideration. Whether there is any previous or current treatment that is going on. Okay, that has to be considered. Then current fitness level of the patient has to be taken into account, and past and present exercise participation, whether the patient is used to do any kind of exercise or he or she is new to the exercises. Okay, because if anyone is new to the exercises and you suddenly start with some vigorous activities, they are not going to comply, they are not going to like it. Okay, so you'll have to gradually progress. But in fact, if somebody is used to exercises, then yes, they have a good idea about what all is going to happen and they will comply. Okay, also taking into consideration patient's preference would be better. Like some of them might like cycling, are interested in cycling, you can start with cycling as a form of aerobic exercise. Or somebody likes swimming, you can encourage them to start with that and then gradually add other exercises as you progress. Okay, so these small things have to be taken into consideration. And ultimately, I would like to say is cancer management will always require a multidisciplinary team. It's not just one person taking care of the patient. It's all the team members who take care of the patient. Thank you.
Thank you, ma'am, for the wonderful presentation regarding that cancer-related fitting, elaborating the ways to prevent it and the exercise and everything. Now it's open to all our participants to come up with some doubts or some comments regarding this session and all. So I request all our participants to come up.
I have a question.
Let's leave it. Go ahead.
Or should I put it in the chat?
You can ask.
No, you can
I
ask.
can ask. Okay. See, actually, I want to know because I am also a cancer survivor. So I just want to know one thing, like, is this mostly seasonal, like, winter fatigue or summer fatigue? Because mostly I feel very, very fatigued by end of the week, whether it is like, whether it's summer or winter. But winter is comparatively better. So I just want to know whether, it has anything to do with the temperature.
Okay. I haven't actually come across seasonal variations, but probably in summers, maybe if the water intake is low because of dehydration, the levels of fatigue might increase.
So is like, nausea one of the, what you call it, symptom of it, or like feeling nauseatic?
I don't think so. Nausea would
No.
be a symptom of it. No.
Okay.
For fatigue, dehydration can be one of the reasons. And as temperature increase and if the water intake is less, then that might cause to some fatigue.
Okay. Seriously, thanks, because I was after James with this fatigue part of it. I don't know how to manage, even though I do my yoga regularly, I walk 5 to 6 kilometers every day, but still, I'm not able to. So you were talking about the exercises.
Yes.
I don't know what else should I do so that, I feel more energetic.
Right.
Really nice. Thanks.
Thank you.
Thank you, Diva ma'am. And Priyanshu, Dr. Priyanshu has raised her hand. Dr. Priyanshu, do you want to ask anything?
Hi, ma'am. First of all, congratulations for a wonderful presentation. That was really very knowledgeable. So my question to you is, as you mentioned that we have to assess for the physical fitness of a patient. And my question to you is, for a cancer patient, what is the strategy or what is the scale or what is the tool we use to assess the fitness? Is it the same what we assess for any other patient, or it is a different scale or any tool we use?
It would be the same. It would be the same. Just that cancer patients will have variations. Like, for example, if there is any other person, maybe who has come out of any major illness or surgery, initially the levels of energy or the baseline would be little lower, but as you progress, it will improve. But for cancer patients, as I said, there will be rise and fall. Even during depending upon the treatment, there can be rise and fall. So the assessment tools would remain the same, but you have to do that assessment frequently, or you have to, like if the patient is on treatment, you have to be extra careful while you're prescribing the exercises.
Thank you so much, ma'am. That's it.
Thank you, Priyanshu. Anybody else? If you have any doubts or any comments, you can come up by unmuting yourself, or you can put it in on the chat box. Now, Dr. Gagi has something in our chat box. It's like sometimes exercise also cause fatigue in palliative care patients, and what can be done for that?
Yeah, so then maybe you can reduce the number of exercises. Not all the exercises need to be done. They can be broken up. Like the patient need not do all the exercises at one point of time. Maybe we can try breaking it up. One set of exercises done in the morning. The other can be done maybe in the afternoon or evening. Okay. Or again, as I mentioned, the fatigue levels are different at different points of time. So if when the patient is feeling energetic, maybe some exercises can be added during that time, that way. So that type of changes can be done.
Yes, thank you. And I think in addition to that, we can do some exercise tolerance test or something. So it will be beneficial for patients. Actually, it varies from person to person, and from gender or related to age also, it will be varying.
Yes.
So according to the, as you have mentioned earlier, we can tailor exercise program for each and everyone differently. So it will be more useful, I think.
Yes.
So anybody else? If not, I think we can move on to the case presentation now. And for today's session, Dr. Priyanshu will be giving a case presentation. And I welcome Dr. Priyanshu for that. Over to you, Dr. Priyanshu.
Hi, good afternoon, everyone. Am I audible? I think, yeah.
Yes, go ahead.
So, so I'm Dr. Priyanshu, and I'm a physiotherapist to Homi Bhabha Cancer Hospital and Research Center. I work in the Department of Palliative Medicine. And this is a case of a 48-year-old female who was diagnosed with carcinoma cervix type 4B. Her cervix biopsy showed squamous cell carcinoma, which was moderately differentiated. So her presenting complaints to us was heavy bleeding per vaginal, multiple episodes of vomiting since a week, and persistent nausea. She also had a history of fall, which caused her severe back pain post the fall. The other complaint she mentioned was severe fatigue, and on NRS, it was 8 out of 10. There was foul odor per vaginal discharge, severe psychosocial distress, insomnia, and palliative performance score was 50% on the visit to hospital. So this palliative performance score, can you please, yeah, thank you. Basically, it accounts for the performance score in palliative patient. So here we address basically the mobility and how the patient is dependent or independent, is patient dependent or independent on basis of daily activities. So if I say 50%, that means the patient was actually not mobile. She was either sitting or moving with the wheelchair. Okay, next slide, please. Now, when we see the psychosocial aspects of this patient, she was an advocate by profession. She lived alone and independent all her life. There was family collusion, and she was also a divorcee. She had a fair insight to disease, and her family was not very supportive. She had 7 siblings who were living in the station, but although in spite of that, the family was not enough supportive. Her primary caregiver was her colleague. Due to her fatigue and pain, she was unable to do her most of the activities, which primarily cooking was very difficult for her. And we see generalized anxiety disorder, so that is GAD-7. Her score was 11. That showed her she was moderate anxiety was present. She also had suicidal thoughts and self-harm. There was also questions of why me, and she was self-blaming herself. Next slide. So when we see the history of illness, she had a history of heavy bleeding per vaginal since 7 months, white discharge with bleeding episode, and she was on tab Trenexa 500 mg 4 to 5 times a day. So ultrasound in the government hospital was done. She was advised to do a USG abdomen, CT abdomen, uterine, and I'm unable to see the other side. 1 second. Yeah, thank you. So uterine and cervical biopsy was taken. She was diagnosed with carcinoma cervix, non-keratinizing squamous cell carcinoma. There was history of 4 units of blood transfusion in September 2021. Increased frequency of urination. I suppose it was back from 7 months. History of spontaneous miscarriages. That was 2 times in past. She had no children. So when we come to the treatment plan, according to when she came to our hospital, she was seen by medical oncology in our hospital and was suggested to discuss further in the joint clinic for further planning and management. She received 10 fractions of hemostatic RT first. Then she was counseled regarding the disease status and prognosis. The caregiver and the patient was also given option of stenting, percutaneous nephrostomy, dialysis discussed with attendant. The pros and cons were explained to both patient and caregiver, and potential futility of care was also explained. There was guarded prognosis that was explained in detail by oncology and the palliative care team. The shared decision making for conservative management and observation was done, and the plan was best supportive care. So examination, when we see the CT abdomen and pelvis showed a heterogeneously enhancing mass in the cervix. There was uterus enlargement containing many intramural hypodense lesions, likely suggestive of fibroids. Her histopath showed endometrium biopsy that already involved squamous cell carcinoma. This was her previous history. And in the hospital, when her biopsy was taken, it was squamous cell carcinoma moderately differentiated. Her labs as on 8th of 11/2021 was 8.2 hemoglobin gram per deciliter, and on 4th it was 9.30 gram per deciliter. Please mention, I have mentioned here serum creatinine and serum urea. I will explain later why. So her creatinine was considerably high and the urea also was 116 milligram per deciliter. Now, when we come to treatment part, so we started with the screening. So you always observe for questions. We observe for questions. The words like generalized body pain. She complained of shortness of breath, tiredness, inability to perform her daily activities, insomnia, and loss of appetite. So these are the words we observe while screening. Then while primary evaluation, we use the VAS scale, that is visual analog scale and NRS scale. Her disease trajectory basically was she was receiving hemostatic RT. So that basically counted for radiation induced fatigue. She was also anemic mildly, and there was a lot of psychological distress. Environmental factors, she used to live in her house alone. So that was one other reason why she would be forced to perform her activities herself. and she cannot ask anybody to do so. So that was one other factor. When we come to interventions, so I've divided interventions in 3 segments, that is symptom management, psychosocial intervention, and physical therapy intervention. I'm not able to see the last line. Can you please? Can you go back to the last slide, please? Thank you. So then the reevaluation that keeps modifying as the disease prognosis and disease trajectory, we modify the reevaluation. Symptom management, always focus on correcting the correctable first. So as you saw that she was already bleeding. So her bleeding was stopped by palliative RT. She was receiving palliative radiation. She was on tab ethamsalate. Okay, it is ethamsalate. I'm sorry. Ethamsalate 500 mg SOS. For the pain, she was started on CEP3 opioids and adjuvants. Started with tab tapentadol 50 mg TID and tab paracetamol 650 TID. She is currently on buprenorphine patch 10 microgram, and that is to be changed per weekly. For the odor, tab metronidazole 200 mg TID for 5 days, and then thereafter maintenance dose was given 200 mg. For nausea and vomiting, she was on tab olanzapine 2.5 mg HS. So there has always also been evidence of using steroids in fatigue. So for that, she was on burst doses of steroids, dexamethasone. The psychosocial interventions, there was supporting counseling done for both patient and the caregiver who was her colleague. She was on constant phone calls with the IHCC team. So we have an integrated hospital-based caregiving team who called her and kept monitoring her status and vitals. And a home care was done for this patient, which empowered the caregiver and the patient both. Coming to the physical therapy interventions. So initially we started by generally educating the patient and caregiver with regard to disease and the associated symptoms with the disease. We asked the patient to maintain a diary herself, to monitor and to keep track of energy levels as to when her energy was at peak and when was it diminished, so as to prioritize her activities accordingly. Next, what we did was her energy conservation technique. We asked her to set the priorities. So according to her, the priority activities will always remain her basic daily living activities. That included, so from morning getting up, doing her routine activities to administering drugs herself, right? So for that, setting priorities and then pacing activities. Again, when we say pacing activities, for a normal individual, we might require maybe 100 steps. For example, if 100 steps or 200 steps to go to some place. That for that, if we take 5 minutes or 10 minutes, maybe those people can take around half an hour, take breaks in between, even to go to the washroom. They can sit and divide the steps into pieces, bits and pieces. Again, the next thing is delegating. So what is not important, what is least important, delegate the activities to other person. Scheduling activities at time of peak energy. So this accounts for why we asked her to maintain a diary for herself. So whenever her energy was at the peak, that is the time when she could have done most of her activities. Now, labor saving devices that included using of wheelchair in and around the house or using a bedside commode. Postponing non-essential activities, again, it is understood. Then also maintaining a structured daily routine. Taking naps in between, if it is required. Also mention that it is not disturbing the night sleep. So we asked her to take naps in between without disturbing her night sleep. Distraction, for distraction, she used music And she also, as mentioned, she was an advocate. She loved to talk to people. So the other way of her distraction was socializing. Although she was living alone, but she managed to get out of the house and talk to people. Now, we also started her with some minor exercises, that is walking in and around the house, and then maintaining proper nutrition and hydration. So for her, the red flag signs and the caution was fall risk. As mentioned, she already had a history of fall. So fall risk was one of the major red flag sign. Next thing was decreasing functionality. Also bleeding, she was bleeding. The other red flag sign was vomiting and then delirium. As mentioned, she was on buprenorphine patch 10 microgram, olanzapine 2.5 mg HS, tapentadol 50 mg SOS, ethamsalate 500 mg SOS, and laxatives. So to summarize, we see what was her main concern. When we see from physical aspect, she was unable to do most of her ADLs due to fatigue and pain, tiredness, breathlessness on exertion. So her PPS was 50% when she came to us on the hospital on 30th of December. On 14th of March, when we did a home visit, her PPS was 60%. Now, when we see psychological concerns, dignity was one of the prime factor that disturbed her a lot. As mentioned, she was an advocate by profession. So having a wound, having a cancer at cervical region, it is a social stigma. So that was one reason why her dignity was at question. Suicidal thoughts, then there was family collusion. She used to live alone and there was severe distress and anxiety. So when I remember when she came to us in the OPD, there was a lot of distress and lot of anxiety. She basically did not wanted to live anymore. She was saying things like, I want to end my life and all of that sort. So there was severe distress, but what we observed. Now, when we see the socio-economic concern, did not have enough family support, obviously, although she was financially independent, but she could not keep a full-time maid because it would become a little bit difficult for her. Spiritual concerns, she always mentioned that she believed in Jesus and that Jesus will help me through all of this suffering. Also, there was self-blame that why me and why am I to suffer? To summarize, so basically fatigue is a very subjective experience. You always go by what patient says. Now, always address the descriptors like onset, duration, and symptoms. As mentioned already by Gayatri ma'am, that fatigue is it's multifactorial. So when we see pain, so for her, the factors that denoted to her fatigue was pain, bleeding, nausea, odor, psychological distress, and the fatigue itself. So when you see NRS was 8 on 30th of December, which transformed to NRS 4 on 14th of March of 2022. So you see that gap and you see the change that happened. Always educate the patient and caregiver about fatigue, the cancer related fatigue. Sometimes the fatigue itself gets treated when the treatment trajectory is over. If the patient is on chemo or radiation, the fatigue itself gets treated. It gets better on its own, and sometimes it might not. So educating the patient and caregiver, it is very important. Early referral, of course, when the patient is seen by the physicians, early referral is a must. Sometimes what happens is fatigue is a very outlooked symptom. We overlooked it. Also, yeah, non-pharmacological interventions, as mentioned, that includes everything. I explained about the physical therapy intervention, that is energy conservation technique, minor exercises, aerobic exercises. Pharmacological intervention that includes always correct the correctable first, address the multifactories, the etiological factor behind the fatigue, and also a multidisciplinary approach. Fatigue should be addressed in a multidisciplinary approach. So these are the discussion points. What are the assessment scale used for cancer-related fatigue? How will you address fatigue in pediatrics versus adults? And then how do you explain or how do you plan exercise regime for cancer-related fatigue? Next, last is what are the barriers in early diagnosis and management of fatigue? So lastly, I would like to say that what is the take-home message after this presentation is that, see, we did not do much of the changes here. We did not do anything to the disease prognosis. We did not do anything to labs or anything. These were some minor changes that we did that helped her to feel better on herself, and the fatigue improved with some minor little changes and minor help. Okay, thank you. If there is any question, you all can put it up. Thank you.
Thank you, Dr. Priyanshu, for the wonderful presentation. And the participants, we can go through these discussion points that Dr. Priyanshu has put up, like what are the assessment scales used for CRF. And I think for this patient, you have used NRS, right, Dr. Priyanshu?
Yeah, for this patient, we have used numerical rating scale, but that is from 0 to 10.
Yes, okay, thank you. So I think other than that, we can do some brief fatigue inventory BFI scale we can use, I think, for this question. And it's over to all our participants to open up and come up with some comments or your comments and questions regarding this patient, this case and all, and our discussion points. Either you can unmute yourself and speak up, or you can put in chat box. The first discussion point, as I mentioned, what are the assessment scales used for cancer-related fatigue? And the second one is how we'll address the fatigue in pediatrics versus adults, or in adults. Then how to plan exercise regimen for cancer-related fatigue. And the last one is what are the barriers in early diagnosis and management of fatigue. So as we have discussed, fatigue is the most common and complex symptom experimented by patients with advanced cancer or with cancer. We have to tackle this problem by doing some at least in some sort of fatigue we can reduce by doing some active exercise. And I remember I have read in one article recently, but not recently, in around 2017, and they have done a randomized control trial in 60 breast cancer patients, and they were giving some active exercise for upper limb and lower limb, then some techniques of MF, myofascial release, and some techniques of PNF for upper limb, and the result shows like good results regarding in the one half of the patients who were receiving the exercise. So any of our participants have any comments or any question regarding this? can come up and speak.
It was a very nice presentation, Priyanshu. I would like you to mention, like you mentioned that the PPS was 50 at the beginning and later it improved to 60, right? So can you mention, like for just for others to understand, like what was the difference in the level of activities or things that she could perform?
So thank you, ma'am. And so basically, when she came to us in the OPD, as mentioned, she came on wheelchair. And she complained that it is very difficult for me to even get up and go and make a cup of tea or make a cup of coffee for herself. She would not want to get up and look who is there on the door. So that was the difficulty what she was facing in performing her ADLs. Now, after we did a home care and after all the corrections that was made in her labs, and also when the fatigue was addressed by me and other team members of our, so she welcomed us when we went for the home care. She came to the door and we could see that she went in the kitchen and she's walking around the house. And she said that, okay, I am able to perform my activities without much difficulty. These were the words that she used. So that accounts for, obviously, like her PPS from 50 to 60, it was improved. She was not actively dependent on anyone to do, like get her something or get her something from the shop, or maybe make a cup of tea or make a cup of coffee.
Thank you. Also, to answer this question, like barriers in early diagnosis and management, as I mentioned, early diagnosis cannot be done because of the patients not reporting about it, or the physicians not aware, or the physicians not being aware about the presence of fatigue or the availability of the treatment options for the same. Okay, so that awareness amongst the patient as well as the clinicians has to improve.
Thank you.
Are
Thank
you
ma'am.
aware of, sorry,
Yes. Go on, Priyanshu.
I was just wanting to know this question, if anybody is aware of, like, how will we address fatigue, if there is any difference how we address fatigue in pediatrics versus adults when we see.
So for this thing, for assessing, there are different scales for pediatric population, and so there are different scales which are available, so that can be used for the pediatric population.
And the exercise regime plan remains the same.
Exercises, now depending upon the age group, you'll have to, like if the patients are very young, then maybe you can have you will have to include more of playful activities rather than exercise, which the kids will not be interested in doing. If they are like 10-12 years or above, then maybe you can ask them to do certain exercises, that would be fine. But for younger, like smaller kids, it's better to include some playful activities which will work on different muscle groups, different activities which will address different muscle groups. That way you can add.
So if I would just like to answer that first question, what are the assessment scales used for cancer related fatigue? So as mentioned by ma'am, there is brief inventory scale, then that is single tool assessment. When we see multi-item tool assessment, it has a multifactorial inventory scale. Also, there is something called as Edmonton Symptom Assessment System, that is ESAS we use. That is very commonly used in our department, ESAS, which accounts for many symptoms. So fatigue is one of them. And then NRS, obviously. Okay, that's it. Thank you.
Thank you, Priyanshu. Can you just explain me that SS scale regarding what all the this one?
Okay, so ESAS stands for Edmonton Symptom Assessment System. That includes your pain, your nausea, depression, anxiety, fatigue, breathlessness, loss of appetite, loss of well-being. So these are some 10 or 9 items in the scale, and that accounts for the 0 to 10 is the numbering we do accordingly.
Okay, thank you, Priyanshu.
Thank you.
So anybody else would like to come up and comment something or ask any doubts related to this case presentation? If no, I think we can wind up this session. If you have any doubts or comments, you can put in our WhatsApp group also later. So thank you, Priyanshu, for the wonderful presentation. And I thank Dr. Gayatri Karnik for the wonderful session and in the comments and valuable information for us regarding this case presentation. Thank you, everyone, our participants, and over to you, Sri Priya.
Thank you, Mr. James. Thank you, Dr. Priyanshu, for bringing in that wonderful case. And yes, of course, thank you, Dr. Gayatri, for your valuable time. We do understand how busy schedules you all will be having, and that you found out time for this cohort. We are very thankful for you to that, and we look forward to have such wonderful sessions with you in future as well. So with that note, this is Sri Priya along with Mr. James Das and Dr. Gayatri signing off from the Tips Echo Desk. See you in the next session with another interesting topic and another eminent faculty. Till then, everyone, stay safe, stay healthy. Bye-bye.